All right, good morning, everybody. I am Kate Liebesny, and I am one of the child psychiatrists here at Carilion. I'm going to get to my own introduction because Dr. Borowitz is under the weather. So I have been at Carilion since August of 2026. Hard to believe it's coming up on 10 years now. I have been the Child Adolescent Psychiatry Fellowship Director since 2022. And I've done a bit of all of the things since I've been here at Carilion. So I've done inpatient and consults and outpatient. I'm currently practicing outpatient, jumping back into consults soon. And my areas of focus have been family therapy and gender nonconforming kids and eating disorders. I also have had the opportunity to teach for VMAP. And so I really enjoy teaching in all different formats and particularly enjoy the opportunity to teach across disciplines to other folks who work with kids and families. So I am going to talk a little bit today about beliefs and bridges and basically one of my passions, family therapy. And I don't have any disclosures. So what we're going to do is I'm going to frame what I call some common challenges or disagreements that happen in the room when we're working with kids and families, things that I think are pretty universal to all the types of practice that we do. And I'm going to teach you guys 3 family therapy interventions. And my hope here is that as I teach them, you recognize that these are things that you do intuitively. You just don't necessarily have fancy words for what you're doing. And so the goal is to move from doing them intuitively to intentionally for better effect. And we'll practice or I'll give some cases to illustrate what do those things really look like in a non-psychiatric kind of setting. So what are the common disagreements that happen in our clinical rooms? Parents and kids don't get along or don't see eye to eye, right? That can be about any number of things, but when it's going on pretty pervasively, then you're trying to have a conversation about something relative to your clinical care, and it's getting in the way in your room, okay? We also have parents and kids not necessarily seeing the problem the same way, or perhaps more commonly, families not seeing the problem in the same way that we're seeing them. We have different beliefs about what we think is going on, what's driving the issue. And then we can often have 2 parents who don't agree on the nature of the problem or the right solution, and we're navigating that kind of disagreement. So just for a little bit of framework, there are many types of family therapy, just like probably people are familiar that there's CBT and DBT and psychodynamic therapy when it comes to individual therapies. Family systems therapy is one of the schools of thought and kind of modalities of family therapy. And the way the family systems therapists think is they say, okay, families are a system. Each part is part of both what makes the system work well, but also plays a role when things are not working well, right? So there's no one person who is at fault when the dysfunctional pattern is going on because everybody plays a role in maintaining healthy and dysfunctional patterns. And so in these family systems, we can see some common sources of tension that build up. So one natural tension is what's good for me versus what's good for the whole group, the family. Another common tension is our responding styles to problems being very different. The person who wants to think a lot about it, the person who wants to leap into action, the person who wants to talk all about the feelings, the person who's like, no, I don't really want to get into that feeling stuff. Okay, so these different sort of modes of responding can cause problems. And then how we think about our roles and our boundaries in the family, and when those are either in conflict or they're actually falling apart. The proper sort of boundaries, as the way these theorists think, are coming unglued. So When you have tension in a family system coming from any one of these things, there are some 4 common patterns of what families do. First common thing is everybody goes in their own direction. People go into their own bedrooms, stop communicating, there's distance, and people are siloed. Very, very common. Another common thing is conflict. We're like having on, yelling, screaming matches. We can also see that when there's a mismatch between avoidance and conflict, the resolution is that one person, that avoidant person, tends to compromise their goals and needs for the sake of the person who is a bit more dominant in the relationship. So one person kind of sacrifices for harmony. And then we can sometimes see something you might hear us call triangulation, where 2 people come together over a mutual concern. Sometimes that's very effective, but sometimes it can be problematic, especially if that triangulation shifts the natural roles and hierarchies in the family, like a child and a parent come together, isolating another parent. So, what are we going to do? We're going to talk about 3 family therapy interventions: joining, bridging, and reframing. So, in joining, we need to identify who in the room is on the outs of this conversation. And when I'm looking in the room, I'm looking for one of a couple of things. I'm looking for who looks checked out, be here, who is feeling blamed and like everything is being put on them, and who is feeling so much in disagreement that they have sort of moved themselves to that sort of edge of the room and they're not really participating. When you identify that person, we want to really reach to that person. The first step is to really bring that person back into the circle of the conversation. So we're going to invite them to participate. We're really going to work hard to get their perspective and to do a lot of validation of their perspective and also of the importance of their participating. So it's a lot of validation of that person. The next step is bridging. So I'm joining with that person who's on the out. That sort of builds a connection between me and that person. Then my next step is to use myself to bridge between the 2 people in the family that are not getting along or are distanced from one another. And I'm going to do that by using my own curiosity and concern and invite more curiosity and concern between the 2 people. So in medicine, we do a lot of linear questions. How is your pain today? What do you think is causing your rash? Okay, that's just like, what do you think, and tell me. In this type of family work, we want to start practicing more circular questions. And that means asking one person in the room to speak about the thoughts, feelings, or motivations of somebody else in the room. Why do we do that? Because if I ask you, teenager, why your mom wants you to put up your phone by 9, you have to think from your mom's perspective to answer my question. And that invites an opportunity to see how accurate is your understanding of your mom's perspective. How well do you understand her point of view? And you do it in the opposite direction too. Mom, why do you think that it's hard for your kid to go to school? Are you able to think from your child's perspective so that you have some both empathy and understanding of what your child is experiencing? And then we're able to move to some reframing. The big concept of reframing is often the opportunity to take a new perspective on the problem. And in most cases, we're trying to either come up with a more positive look at it, more strengths-based look at it, or maybe in some cases in our medical work, a more accurate look at the problem so we can move forward with a treatment plan that makes sense. So you can reframe using questions. So you can ask things like, as frustrated as you are, what makes you the most sad or anxious? Classic question from one of my mentors. People are often much more aware of their anger and frustration. Kids are often much more aware of their parents' anger and frustration, but there is almost always an undercurrent to that that is about worry, concern, and fear. And so we're inviting a different perspective. This isn't just, I'm frustrated, I am very worried. That's a lot easier to work with moving forward. Another reframe might be like, what are the ways you would like to see your child advocate for themselves? I'm flipping the scenario that this kid is disrespectful and disobedient and saying, well, they're trying to advocate for themselves, they're just not doing it in the way that you would like them to do. And so I'm kind of turning that around using a more strengths-based language. Probably many people have seen memes to the effect of, I'm not bossy, I just have leadership skills, right? That's what we're doing here. We can also use reflective statements to reframe what's going on. So a very common one in work that I do is about kind of the grief process. So a lot of families avoid talking about painful things because the underlying assumption is that to talk about it is going to cause people you care about pain and suffering and sadness. But what happens very commonly when you don't talk about the difficult thing is that everybody has to grieve by themselves. And that's a very painful process. And so when you describe that in a reflective way, you are able to kind of help the family understand the intention here was very good. We're trying to prevent suffering in people we care about. But the end result is that actually we're brewing more hurt, more resentment, more sense of isolation. So we're reframing. So let's get into some cases that I hope will feel a bit more familiar than some of these terms. So we have Jenny. She is an 8-year-old with abdominal pain that predominantly happens on school nights and mornings. And her parent comes in and is just like, we need to see GI. And there is a family history of IBS and maybe some IBD, but the labs are reassuring and the review systems does not really red flag for things like severe diarrhea or hematochezia or weight loss. And you'll notice in the room that this little girl is pretty shut down. Her mom talks over her a lot and seems to kind of want to rush the visit to provide an efficient history. So a little audience participation. What disagreement do you feel like is sort of most described in this case scenario? Is it conflict between the kid and the parent? How the parent is believing what's going on in the room compared to maybe what you're thinking? Or discord between two parents?
Parent belief about child problem.
Parent belief about child problem. I would agree. Because I read this case scenario and think, I think we have some anxiety of school avoidance, and I don't think this is really a belly problem at its origin. But this parent seems to have a different belief, and that's why they're asking to see GI. So if mom's belief is that the abdominal pain is caused by an organic problem rather than anxiety, then one of my tasks, if I want to kind of move in the direction of treatment that I think is most helpful, is to help move that parent towards a more shared belief with me about the origin of the problem. So the person I have to join with, the person who's kind of on the outs, is mom, mostly in this scenario. So some strategies. What are you most worried about, Mom? Really help her describe what she's really scared about so that you can use your medical knowledge to educate. Well, here are the reasons that I'm not as worried about some of those big, bad, ugly things. Validating the concern that there's something really wrong is something we're always doing. And then I think it's really important in these kind of classic psychosomatic cases to also validate the desire to have a very concrete answer and at least the assumption of very concrete solutions. That if this is Crohn's, there will be a medication for that, right? We know it's more complicated than that. But the goal here is to help mom feel very understood and very supported so that she's more receptive to what if we explored some alternate ways to look at this problem. So bridging that we need to do, we have kind of helped mom feel supported. Now we want to bridge between this parent and this child because we're getting the feeling in the room that this kid doesn't have much of a voice and maybe doesn't feel like the parent appreciates what's going on. So you can use your circular questions. Ask mom, what does Jenny think is causing her tummy pain? My best guess is the answer to that question is, I don't know. So it's an opportunity to invite curiosity then. Well, let's ask her. Let's talk to her. What is it like for your kid to feel bad? In many of these cases that I have sat with, parents have gotten a lot of calls from the school nurse. They've had to pick up their kid frequently. Work is being disrupted. They're under a lot of stress. And they are getting increasingly frustrated at both the medical system, the school, and the child because it's causing so much tumultuousness in their lives. So building some opportunity to recognize that no matter what's going on, this kid is feeling badly at school. And then asking, what do you think are the stressful parts of school for your child? This kid may not have the experience that mom is attuned to what her school day is like and really understands all of that. And also, we always want to think, right, about the things that help so that we can build on those. So what helps her feel better? Our goals here are we're increasing empathy, we're helping this child feel better understood by her parent so that their relationship is stronger and they are more likely to be able to do some teamwork to work towards the things that we think will be helpful here. So we're reframing. As frustrating as it is to keep getting calls from the school, what makes you the most sad for Jenny? Jenny's hearing a lot of frustration. She's seeing a lot of anger in her parent. She may not perceive at all that there's worry and concern about her. We're bringing that into the room very intentionally. A little stigma challenge. What would be worse if the workup revealed Crohn's disease or anxiety? It's incredible how many of us have a bias that a very serious chronic medical disease is somehow better than a highly common mental health concern that is also highly treatable. So it's an opportunity to challenge stigma and educate. If your kid could feel less stressed at school, how would that affect the relationship? Would you guys be closer or would you be further apart? This is a way to bring some awareness that these conflicts and tensions are affecting relationship and to also start building some awareness about how relationship is being affected. Many times, stress and problems, as I said, drive people apart. Occasionally, stress and problems bring people together in a way that leaves people wondering, well, if we solve the problem, will we lose this opportunity of togetherness, right? And that is how children get entrenched in the sick role because it brings them the TLC and the teamwork that they are really craving from their parents. So then we've got to do the work in my office, in Lori Dudley's office, in Tara's office, for how do we help you guys maintain closeness in a way that isn't about this illness role. And that's a thing to be done, not necessarily in y'all's office. So big summary for Jenny. We've joined with the parent and helped them feel better understood. We've clarified that there's a role for anxiety in this presentation that may or may not lead us to using GI as the next step. Jenny has seen her mom as more worried and understanding and empathetic and not just anger. And they're able to work more together because they have a more common understanding of the problem and they feel like they have a connection and an ability to move forward. Different scenario. So Sam is a 17-year-old who is frequently up late and late to school, spending a lot of time on a screen, usually a phone. Sam is being raised by a grandparent, and there is a lot of arguments in this household about going to bed. In these arguments, grandparent frequently invokes that, I never talked like this to my parent. I never, this is not how we speak to adults. We need to have more respect. And Sam tends to sort of disengage, roll their eyes, slam their door, back away from the conversation. So, which disagreement do you think is most illustrated here?
The first one.
Parent-child conflict, exactly. So we have a problem here. We have a parent and a caregiver who have a relationship strain that we see a lot. And I know that I think it was last year you guys had a presentation by my colleagues, Dr. Khalid and Dr. Ratnakaran, about grandparents as guardians and all the generational kind of challenges that they face. But there are different expectations of teen behavior, and this can happen in many different dyads, not just kids and grandparents. And there are very different ways of relating to technology and thinking about social interaction in these kind of systems. So we have some important tasks in front of us. One is we do need to help this grandparent understand this teen. We are sort of a generational bridge, many of us, between these two individuals, and that can be an important role. We need to help the teen also understand how important it is to respect and behave appropriately towards a caregiver of any age, and help them problem solve developmentally appropriate outlets for socialization, because we know how important socialization is in this phase of development. So I would argue that in this case, both parties need some support with joining. So we have a teenager who's probably like this in the room, just like eyes to the ceiling, thinking this is not going to be productive whatsoever. And we have a grandparent who might be quite flustered and frustrated. So when it comes to Sam, I think that, we have to lean in and express that we do understand Sam's perspective and give some validation about, in your generation, there's a lot of use of technology to facilitate social connectedness. And we need to also kind of have opportunities to do this that aren't completely dependent on your phone or keep you up all night. So collaborate with me, help me generate some of the ideas and solutions for where else you can be socially connected. And with the grandparent, a lot of times they need our backup. Like, they need us to also say, like, you have to respect your parent or your grandparent. They need us to validate that their concerns about sleep and going to school are not off the wall, right? They need their kiddo to hear that from another grown-up as well. And we can invite their perspective. Where would they like to see this kid socialize? Do they see that importance quite the same way that we do? Always important, I think, with any parent that you're working with, caregiver, to check in about what support they have, because we're likely going to identify some barriers. What support system do they have to facilitate this? Often they want it for their kid. They're just having trouble executing it or resourcing it. So being curious. So our bridging, hopefully we've kind of built a little rapport stability with each person. We're inviting perspective. What is your grandmother most worried about? What do you think she thinks about time with your friends? Is that something she thinks is actually important for you? What might make it hard for your grandma to take you to the practices to be part of that play that you wanted to be part of? Inviting perspective and grandma's thinking, her feelings, her motivations. Similarly, what is it like for Sam to come home after school and not participate in these things that their friends are also part of? As much as you're angry about how Sam's talking to you in this disrespect, what are you blaming or faulting yourself for? How many times have you been in a room and a caregiver asserts that a child needs to be more respectful or take more accountability for their actions? It's incredibly important that we find appropriate ways to introduce the idea that the adults have to model that behavior. You have to be respectful back, but you also have to show some accountability and fault at times to model that behavior. So I might that this grandparent would say something incredibly vulnerable to me, like it's not his fault that his dad's not in the picture. And I know that it's embarrassing that I'm so much older and can't do the things that the other parents in the high school are doing, right? Those are painful statements to bear witness to, but they're real and we can validate them. I also frequently hear some comparisons, and this is sort of a general principle I want to introduce. If you're sitting in a room and you hear something that makes you go, oh, I wouldn't have said that. That's a great opportunity to ask whoever was sort of the ouchlander, ask that person who made the statement, wonder what Sam heard when you made that statement about his dad. So frequently, the person communicating has just no idea that they have said something that landed in a completely unintentional way and that the message was not what they were looking for. So a very concrete example here, might be that you're just like your father was. What does that mean to Sam? That might mean I'm gonna go to jail and struggle with drugs my whole life. Is that really what Grandma was trying to say? Probably not. So by asking that question, we're clarifying, what did you mean really when you said that? Is that what you heard, Sam? And you're doing a little bit of volley here to clarify what the intention was. It happens all the time. So we're going to do some reframe. In this room, the kind of baseline assumptions were my grandparent doesn't understand me and my grandson, teenager, doesn't respect me. Once we've had some of this conversation about what makes it hard and how do you think they think and feel, we're often able to get to places that are much more workable in terms of finding solutions. So Sam may get to a place that says, you're right, my grandparent doesn't understand this technology stuff at all. They had completely different expectations when they were growing up. Spending time with your friends was less important because they had all these responsibilities at home. They're finding it hard to keep up with me. There's a lot more empathy and perspective at this point to then find the solutions. And same for the grandparent. Grandparents can get to a place where, yes, I understand this is a different time that these kids are being raised in, and it can be hard to be raised by a much older generation, and I want what's best for them, and I'm willing to maybe get some help and learn from other people ways to facilitate what they really need. So it's all about shifting that perspective from this beginning stuff, which is so rigid and so unmovable, to I get each other and we can work together to solve this. So over the course of these conversations, hopefully we've changed an argument about respect and rules to one that's about problem solving, how we socialize, brainstorming more supports for this family system to make that possible, and largely really affirming love and connection. These people really care about each other. They just don't understand or agree on this topic of sleep and the phone. Final case. Oh gosh, we started at half-past. I'm always thinking on the hour. So we have Taylor. Taylor is a 6-year-old who is coming in. They have this history of sensory processing, and the parents are coming in saying, oof, we're getting a lot of calls from school about these behavior problems. The reports are that Taylor interrupts a lot. It's often, touching the peers, difficulty staying seated for the seated work. one time got pretty upset, flipped a chair, and attempted to run from the classroom. Both mom and dad are here to talk about this, and mom says to me, my brother has ADHD, and dad says, well, I didn't really care for school either growing up, and so I got my GED and went to trade school because I just get it, school wasn't for me. Some dynamics in this room. Mom is tearful. Mom is wondering, maybe I should have put Taylor in a preschool here to help socialize him to the school. Maybe he's just spent too much time at home, kind of getting to dictate his own interests and time. Dad is like, no, this is a school problem. This teacher is inexperienced. There are too many kids in this classroom. That is why there are problems. It has nothing to do with my kid or how we're parenting. Mom is acknowledging that Taylor can be more defiant with her, but does sort of respect and listen to dad a bit better. And when mom says, is it possible that this is ADHD? I think that's what the school is pushing for. Dad kind of gives us one of those, we're not labeling my child, he's too young to have a diagnosis like that. So our problem here is two parents who really see the situation differently and maybe have different ideas about even evaluating a kid for a concern like ADHD. Who's the most on the outs in this room right now? Dad. Because I think we could say that as the clinician hearing this history from the parents in the school, I'm at least willing to evaluate more for ADHD in this little guy. Mom is kind of on board with evaluating. Dad is putting up the most kind of concern and resistance to having that conversation. So how are we going to join with dad? We want to validate, right? His experience in school sounds like it was frustrating, and he may have some very legitimate frustrations about what is actually happening in the school for Taylor as well. So there's this principle in DBT, validate the valid anytime you can. So we will do that. If we're curious about what made school hard for him, we might be able to start using that as part of our reframe and perspective taking. And it's really important to understand, why are you so concerned about evaluating your child for something like ADHD? Where does that really stem from? We need to do some bridging between these parents, right? Because mom is feeling really vulnerable and blaming herself, and dad's kind of angry and dismissive of the school's concerns. They're on pretty different pages here. So we're going to invite perspective. I might make the assumption that one parent is seeing the other parent as kind of, you're only seeing what's wrong with him and kind of colluding with the school in that way. So I might want to invite the alternate perspective. What does mom see as the strengths, right? Because the other parent is like, there's nothing wrong with my child. He's a really good, active, just all boy kind of scenario, right? So mom sees this kid more than just his pathology. Let's invite kind of more understanding of that. Dad is angry, but he probably has some really good intentions for his child. So asking mom to take dad's perspective. What do you think is dad's ultimate goal for Taylor? These are ways to find common ground. The common ground often being, we have a good kid with a lot of potential. We're just having some struggles in this kind of new arena of school. Why does your husband worry about getting him evaluated? Do you understand his perspective? Why does your wife blame herself? Do you have empathy, compassion for why she is taking that responsibility on herself? Again, kind of strengthening their sense that they understand each other and support each other's perspective. We're trying to kind of clarify also some what we think of as erroneous beliefs, right? That making an assessment doesn't mean that we're labeling a child. So we're going to do some reframing. As frustrated as you were in school, what could have improved your experience? What would have made school better for you? If I learned that, I'm hoping I can use it to say, wouldn't you want that experience for Taylor? To have that experience that you didn't have. Your goal here is to change my child. That's a common assumption in the room. So if I ask, if we could change things for the better, what do you most want not to change about your kid, right? What are some of the core things about your child that you love and find joy in that you are terrified could change if I prescribe a medicine for ADHD or for anxiety or whatever it is, right? Really eliciting those things, because we want to communicate that my goal is not to change your child, and I can provide you some information about how the evaluation or even the treatment is probably not going to change those core features that you treasure so much. How does your kid experience school? And if that stays the same, how do you see that playing out in the future? This is a lot about kind of looking forward and trying to kind of help people say, okay, my biggest fear is that he's going to want to drop out of school like I did, because this is going to continue to be a miserable experience. Tapping into that can really help us get to that place of, so let's do everything we can to try to avoid that, right? And let's start at least with an evaluation of what's going on here. So difficult behaviors are a very frequent cause of parent discord, right? People see things differently and think that the solutions are very different. Sometimes it's like, we just need more corporal punishment to correct the problem. We hear those kind of things a lot. We can have differing beliefs about the problem, but I think in many, many circumstances, the desire to have your kid be happy and successful and have a productive life and happy life in the future is such easy common ground. That's what we need to find, always. Sometimes we need to demystify what diagnosis or evaluation really is and kind of correct some false beliefs. There's rarely value in blame. So when we can identify people blaming themselves or blaming others and clear that out, it is not your fault. Not putting him in preschool is not the reason that we're here and having this difficulty. It just take it off the table, because it's not a place that is really productive. And being strengths-based, really, really taking the time to learn what is positive about this kid and what their strengths are. You can build a lot of goodwill and instill a lot of hope. So ending a little bit here and taking some time for questions, I wanted to kind of share this framework that was shared by my family therapy mentor in training. So when we are kind of taking the lay of the land of these difficult scenarios and disagreements, we're often looking for, as our understanding of the problem, how accurate is it relative to kind of our medical, psychiatric, or psychological framework? Okay, do we have kind of similar and accurate beliefs? And how are things going kind of in the relationship of this various family members? Ultimately, our goals are to move towards shared, accurate beliefs of the problem and more supportive and close relationships. So we can be anywhere in this graph, but that is the direction that we are finding ourselves wanting to move. I want to really, really emphasize that we do not solve these problems in one visit. We do not do it in psychiatry or psychology, and I don't expect it of you guys in your practice settings either, okay? This is about very small shifts in beliefs, small shifts in relationships, and every little bit moves the needle in the direction we want to go. If you do nothing else, focus on your joining. It is the most important step, and it needs a lot of repetition before you can get to the place, what we would sometimes say, the sense of safety in the room, to do the kind of challenging that it kind of takes to do some of that bridging and some of that reframing, right? In our clinical training, this was all termed rapport, okay? Build the rapport So you can ask the hard questions and kind of lead the conversation sometimes in the difficult places. Rapport building is joining. It's joining. If we can validate and be curious every time we have an interaction with a kid or a family, we are leaving them with something so more lasting than anything else hardly that we do. Because that is unfortunately not a common experience in our lives, for somebody to take the time to validate our perspective, be curious about us as a whole person, not just our chief complaint. And it will change whether they come back to you, the kind of conversations you can have, and also for the kids we work with, whether they're going to engage in healthcare and how they're going to do it in the future as they grow up, if they had positive experiences in these ways. So I will just acknowledge that Michelle Rickerby and David McConville were the most impactful people in my training in teaching me about family therapy and making me think about how I can do it not as a licensed marriage and family therapist. And I really appreciate Amy Kreider and VMAP for always challenging how I think about doing the kind of work I do and how universal it is across working with kids and families in all kind of medical and subspecialties. And Dr. Adams for gifting me the opportunity to develop this passion, teach it to our own fellows. So I am really happy to take questions from the online group.
I think someone online has a question.
Okay.
He's got his hand up, so I'm not sure.
Can they unmute and shout it out into the room?
Yeah, they. No. I guess not.
Okay. If you're out there, type it in the chat if that's more comfortable.
It was a mistake.
That's the wrong button.
Misclick.
Yeah.
You probably have many times situations where the parties in the room are totally disengaged with each other and not even engaging with you. To me, that's difficult unless you have very frequent revisits. And in our venue in clinical, we see them less frequently, or we focus on one specific problem. So do you have any recommendations how you can begin to engage the non-engaging?
Yeah, so the question being, they're engaging with you and you don't get to see them very often, but you can clearly see that they don't really engage with one another. Yeah, I think that is where I would use a lot of my circular questions. So I am going to, it's clear they're willing to engage with me. So I'm going to kind of force a little bit more of that engagement with each other in the brief opportunity that I have. So, asking people like, how do you think things are going for the child? What are things that you still feel like we need to work on, or what could be improved? So I think, especially, if the kid isn't very engaged, trying to make sure that you are creating a space for, they might not think that they're supposed to talk in the visit, right? That may not be what they're socialized for, is they're just supposed to come and show up and be examined, but the parent gets to do all the talking and all the deciding. And as they get older, sometimes they get more and more frustrated with that, but they haven't had the opportunity. I know that in primary care, y'all have a lot of good guidance and can be quite methodical about when you start really seeing that kid separate from the parent. I think we do a poorer job of that in subspecialty care a lot of the time, because we don't see them as often and things are kind of complicated. And so we do the whole visit with the family in the room, but when we're not giving that kid that framework to, okay, this is your opportunity to talk to me about your headaches or, your heart palpitations or whatever the correct sort of focus is. So I definitely think trying to take a little bit of time to have the kid and teenager on their own, if they seem like the disengaged party, trying to ask parents to talk about how they think the symptoms are going, how well controlled things are, and then check in with the child. Has mom got it right? Is there anything you want to add? Invite that dialogue. Moving people from sort of the bridging and to the reframing is a lot about inviting the volley. And sometimes we don't want to do that because we're like, oh, this is going to get out of hand. Maybe people are going to start yelling at each other. But if we can actually facilitate the dialogue between them in our rooms, that's very helpful and can be a novel experience because it's not always happening outside.
So this is assuming a normal, I don't know if normal, but a typical thought process from the individuals. What do you do when you add something like a mental health diagnosis for one of the family members or substance abuse? And while their emotions may be valid, their thought processes may not be accurate.
Yeah, no, it's definitely another layer of challenge, right? And you have to kind of decide how well have you joined with that parent that you can bring into the room the fact that their mental health is also affecting their experience of what's going on for their kid, right? So it's easier when they come in saying like, I have anxiety, and so then you could be like, oh, your anxiety must be through the roof about this. And you can really kind of build on that. When they're not bringing that to you, you're in a more difficult position of, if I go out on a limb and label something I think you're experiencing and you reject that, I have potentially strained the rapport that we have. So places of curiosity are really helpful in that way. If you're seeing a lot of anxiety, I might say something like, anxiety runs a lot in families. Maybe I've already kind of made that diagnosis for your kid. Do you think that you struggle with anxiety or anybody else in your family struggles with anxiety? That can bring some parents who don't have the formal diagnosis, don't announce it, to say things like, oh yeah, I definitely have it too. I'm too busy, or I don't get treatment, or whatever. So we can at least, can we acknowledge those things as happening as a first step? And then can we use some education and sort of support to say, I think that your anxiety is kind of causing you to go to that place of thinking about all of the worst case things. And I get that. And my job here is to reassure you that those worst case scenarios that you are staying up all night thinking about are not happening for your child. And I feel confident in that, right? And that's where your authority, your medical knowledge authority can be really helpful. Now, not every person is going to accept that. Some of them are going to, just feel like, you're still missing the big bad thing. But it's what you can do over time. Yeah. Yes, Rachel.
Hey, Kate, that was a great talk. I was listening to you as I was driving. To go back to the first case of the stomach ache, not only do we have to see GI tomorrow, but also she needs to be on homebound. How would you, what's something that you would have in your sort of toolbox, especially for the residents, when that gets dumped out?
Yeah. Homebound is really tricky, and I think I use
Those are the exact words I use. Homebound is tricky.
Homebound is tricky, and I was like the most anti-homebound person ever when I first came to Carilion pre-COVID, right? And then like everybody went homebound for a few years, and hybrid and virtual, and there's so many iterations now that are considered acceptable that it gets really hard to take a dogged, rigid stance against homebound. However, I think there are still a couple of things that we can kind of lean on here, which is In anxiety-based conditions, we know that the best treatment is to face the fear so it can't grow. This is the principle of exposure therapy. And so if we are completely avoiding all of the stressors at school, we're never getting a chance to progressively master the anxiety. And it will just grow and transform and translate in most cases. So it will become harder to leave the house. It will become harder to go to dance. It will become harder to get a part-time job because we aren't practicing the skills that we need. So I really frame it in that way. And when I talk to people about exposure types of work, it is pretty counterintuitive for many people to think that doing the thing that makes you anxious is going to over time make you less anxious. People don't actually have that as a sort of baseline belief. So I use an analogy I borrow from Brady Case, who did a lot of OCD work when I was in fellowship. And so he will ask people, have you ever been in a hot tub or a jacuzzi? Most people have, or even a really warm bath. What is it like when you first put your foot in the water? It's really hot. Do you take your foot out? No. What happens over time? It gets more comfortable. Did the water temperature change? He'll be like, do you like science? Did the water temperature change? And many kids understand that, and they're like, no. What happened? Your brain changed. Your brain changed that sensory input as too hot, painful, to this is actually kind of nice, or just okay. Your brain can do that habituation process with anything, including anxiety and the things that make you scared. So it's helping people just understand what fundamentally is happening when you ask somebody to do hard things under the idea that they're going to get easier and more comfortable.
I know you mentioned a lot of this work happens over multiple visits. Is there homework that you're giving families to make progress in between visits and kind of hopefully dismiss the idea that all the progress is going to happen in the office?
Yeah, I think that's a really thoughtful question. It kind of depends on the setting for me. If I'm sort of doing this type of work in medication management settings that are kind of more spaced out, like the visits that you guys are often used to, I might try to think of some things that I have people practice. When I am doing more sort of typical family therapy work, I'm usually seeing people every other week. And then my mantra is like, unless I specifically tell you to practice something, you leave it in this room. Because the biggest fear that kids have is that we're going to open some kind of thing and then they're going to be sort of nagged or talked at all week for talking about that thing. So I'm very intentional about when I ask people to continue a conversation or continue practicing a skill outside of sessions with me. But I think some common homeworks from sort of the scenarios might be the easiest with Sam and the grandparent, right? So we've identified that socialization is important for Sam. We've identified that driving after dark is not something that you can safely do. What activities could we potentially identify, and who can we identify as people who could support the transportation necessary to make those activities happen for Sam? That could be an example of some really concrete homework that you ask them to do, about kind of moving from, we've generated some ideas, to now what are the next steps to actually sort of solving the conflict or solving the problem.
Question, this can be for you, can also be for the other folks in the audience, but I'm not a general provider. The questionnaires that are commonly given and administered for different topics, ADHD evaluations, depressive evaluations you talk about. In our clinic, we have the asthma control test to really kind of increase efficiency and identify hotspots of problems. But sometimes I'll see that those questionnaires are totally discordant with my assessment of the situation. Is that common to experience?
Yes, it can be. And so I think that screeners and rating scales are great, but we do have to use our clinical judgment to understand what was going on. So if somebody endorses a lot of symptoms that just they're not talking about in the room, I might be curious about, is there something that's making it hard for us to speak this aloud in the room? And is the paper more authentic or more truthful? That might be a really important time to whoever filled that out, the parent or the child, get that person by themselves and inquire about that. Not answering those questions in the room, but what's happening here. The opposite can also be true. Like you're telling me that you're really sad that you filled out this paper as if nothing was going on. In that case, I would be curious, is there something about filling out this paper that was really frustrating to you? Were you worried that your parent was going to see it? Or just help me understand the difference between kind of what we're talking about and how you filled out this paper. I actually had a kid who did this just the other day. He told me everything was fine. I gave him a PHQ-9 and a GAD-7 to fill out while I got his parent. I came back and he had a PHQ-9 of like 25. And I was like, what? So I looked at him and I was like, can we go through this? So we just went through them together. And it turned out that he had completely misread form. He thought he was answering none to all of those questions rather than every day. He was not on his ADHD medicine that day. But the conversation actually brought to me that I think we have a learning disorder here that we haven't identified, because the level of mixed up, backwards, and confused for this 15-year-old was above and beyond what I think should be going on. And so it really helped me say, ooh, we have a totally different problem going on. We need to push on some learning style and learning disability questions. So, does that help answer the question? Anything come up in the chat since we've been talking?
No.
Okay. That's fine. So thank you guys so much for the opportunity to